Okay, so here we go. Child comes out. If it's term, crying, good tone, then you toss it on the mother, cover with warm blankets, and don't worry about it. If it's not term, if it's not crying or breathing, or the tone is crap, then you warm and dry the baby under the warmer, and you stimulate it, and you bulb suction it, mouth first, then nares. At 30 seconds, you check the heart rate. Greater than 100, crying, breathing, good tone, toss on the mother. If the heart rate is below 100, or the child is not breathing, then you're going to start positive pressure ventilation, noting that you will have already suctioned the mouth and the nose. And you're going to look for meconium. If there's meconium, you're going to aspirate that with a meconium aspirator and not just a endotracheal suction because the diameter is not big enough. So you'll aspirate the meconium if it's there. If not, you'll just go straight to positive pressure ventilation. You'll do that for 30 seconds and at a rate of 40 to 60 breaths a minute. That means you'll do 20 to 30 breaths. Usually at this time, you'll have a pink, happy, good tone child that you can toss on the mother. If not, then if the heart rate's below 100, then you're going to reposition the airway, do some more suctioning, pry the mouth open, and continue. At 30 seconds, reassess. If the heart rate is below 60, then you're going to intubate, start compressions at 90 a minute for a total of 120 resuscitation events per minute, which means 1, 2, 3 compressions followed by a breath. So 1 and 2 and 3 and breathe like that. Mm-hmm. You will cannulate the umbilical vein, which is a large floppy one. There are usually 2 arteries and 1 vein. Some children have 1 artery and 1 vein. That's associated with a higher degree of abnormalities, congenital abnormalities, but not always. You should have to take a closer look. You cannulate that vein, and you'll give them epinephrine at 0.5 to 1 mLs per kilogram. Since most infants are anywhere from 1 to 3 kilograms, that means you're going to give, if code card epi, 1 milligram, 100 mics per ml, you're going to give them either 50, 150, or 300 micrograms, so 0.5 to 1 to 3 mLs of epinephrine. Mm-hmm. At 10 minutes time, a dead baby is a dead baby. Right. If they're doing well, you warm them. If they're doing poorly, you cool them. And the criteria for cooling is if they're 36 weeks gestational age and their pH is less than 7, or if it's between 7 and 7.5 and they look horrible, then all you need to do to cool them really is you uncover them, you kill the warmer, and just let them get cool. Things you need to be wary of is their blood sugar can fall precipitously. So you're going to check their blood sugar, and you're going to accept a much lower level than you would in adults. Somewhere between 35 and 45 milligrams per deciliter. You're going to watch their calcium because their calcium can fall. So you're going to replete those 2 things. You're going to do 2 cc's per kg of D5W through that umbilical vein line. The tricky thing to know is that the tools that we use are not reflections of reality. They're windows to reality, and those windows can be opaque or not perfectly clear. So glucometers that we use in adults are calibrated for the range in adults. So glucometers are designed to be at their most accurate between like 90 and 200. If they're higher than that, then they're still reasonably accurate. Once you get above like 350, 400, they're less accurate. Once you get below 70, they're less accurate. So when you have a bedside glucometer and it says 45, you don't really know how low it is. It's going to be very, very low, but how low exactly, we don't know. We tolerate lower numbers in neonates. So typically, if we see 40 and they're not good, we're going to treat them. If we see 60, we'll probably let it ride, but we're going to check it a little bit more frequently. Okay. Okay. The other thing to know is that placental abruption is bad news. So if you know about placental abruption or you see it, you get blood right away because a neonate's blood volume is very, very low. There's not a lot of blood in a neonate, and so they can bleed to death very, very quickly. Meconium aspirator, we talked about how the suction catheter in the ET tube doesn't work, so you're going to suction it. You're going to put it to an actual dedicated meconium aspirator if we have it, and 100 millimeters of mercury suction or less. So we don't want to suck their lungs out of their mouth when we pull the meconium aspirator out. Okay. Right. A few other special situations. If you're an obligate nose breather, and all neonates are, if you don't have a nasal passage, you're in trouble. So when you go to bulb suction them and nothing's coming out of their nose and they're distressed, then you try to pass a nasopharyngeal airway. If that doesn't work, then you have to intubate them, typically. If they have gastroschisis or they're very premature and you can see through their skin and they look like a mutant creature, you cover them with plastic to help with some of the convective blood loss from the loss of water. Okay. And don't put pressure on defective things because they'll break. So if they have a defect in their spine, meningomyelocele or myelocele, you put them on their side or you put them prone, so that we don't put pressure on that. Diaphragmatic hernias are very rare. We will not know about them most of the time, and we won't sure as hell diagnose them. If we know about them in advance, then we'll intubate them right away, because if you're bagging someone and you're just blowing up the stomach in their thorax, then it's not going to make things good for their breathing. Yeah. We talked briefly about congenital heart disease. This is a very, very difficult topic that's got lots and lots of nuances to it. So as a very, very brief 10,000-foot overview, in the emergency department, they come in 3 basic flavors: a mixing lesion or central ventricle physiology, a ductal-dependent pulmonary circulation, or ductal-dependent systemic circulation. Okay. So a single ventricle physiology, we want to keep the blood flow QP to the lung the same as blood flow to the systemic circulation QS, roughly the same. And to do that, we want to keep the resistance the same, which is why we don't try to give huge amounts of pressures to the peripheral circulation or wrap them up in a tiny ball, nor do we want to give them high flow oxygen, which is going to decrease their pulmonary vascular resistance and cause them to shun blood away from their systemic circulation.
Yep.
For a ductal dependent systemic lesion, coarctation is a classic example. When you have a baby that's in shock, you're going to go check all the peripheral pressures. If you have a pulse oximetry difference of more than 40 or a blood pressure difference, then you're going to assume that's the case. And what you're going to do is avoid the use of pressors in that setting because you will do them in. Clean kill. Unless you want them to do them in which case, go ahead, I applaud you. If it's like a strange-looking child or the mother's rude or something. But if it's not the case, if we don't want that, then you're going to give milrinone. Or you could give dobutamine if you don't have milrinone. Milrinone is not as easily titrated, has a longer duration of action, but because it increased cardiac output while giving venodilatation, it's a little bit better in this context. Then prostaglandins, the PGE, then you titrate down the milrinone while dialing up the epinephrine or epinephrine at this time.
Okay. For
a ductal-dependent pulmonary lesion, what you're going to see most of the time is hypoxia and a clear chest X-ray. In that case, we intubate and we give them prostaglandins. For all causes of shock in neonates that are less than 30 days of life, the acronym is the Misfits. Yep. And I will let you see if you can recite it from memory.
From memory? Okay. So we're talking about the T standing for trauma and temperature. H is for heart and various congenital heart defects. Mm-hmm. The E for endocrine, mm-hmm. Hypoglycemia or
congenital adrenal hyperplasia.
Sorry, what did you say?
Congenital adrenal hyperplasia.
The M for metabolic acidosis, of which there can be many causes.
Right.
Misfits. MI, talking about, I'm cheating right now, intestinal catastrophe, like NEC,
right.
Or other more common ones, intussusception type.
It's a little bit young for intussusception.
Right, yeah.
Too young for intussusception. Okay, so that's I. Okay, S.
S would be sepsis.
Mm-hmm. Yeah, you can sepsis there, that's fine. F.
F would be...
This is an important one.
Or formula.
Right, very good. Okay, next I.
Inborn errors of metabolism.
Mm-hmm. T, the one I missed.
T is for toxins and
toxins, and the last S.
Seizures.
There you go, done. So that's our differential diagnosis for shock in under 30 days of life. Very good, very good. All right, man. So that was a very, very rapid breakdown of neonatal resuscitation. The key thing to take home from all this, if you can remember one thing, it's this. In neonates, they die because they don't have air. Most of the time. Bradycardia is a sign of hypoxia. So you treat the heart rate by treating the breathing. You don't treat the heart rate by itself.
Okay.
That's the take-home point. It's different from adults. That's why atropine's not the thing to do, unless you're a fuck-up.